Diabetes mellitus is one of the most common feline endocrine diseases. The latest clinical and histological evidence now suggests that type 2 diabetes mellitus, or DM, is the most frequently occurring form of DM in cats. Type 2 DM in cats is characterized by an impaired ability to secrete insulin following a glucose stimulus and is caused by both a defect in pancreatic beta cells and by peripheral insulin resistance. The etiology of type 2 DM is multifactorial, with obesity, genetics, diet, and amyloidosis of the islets involved in the development. Epidemiologic studies have shown that physical inactivity and indoor confinement, rather than the proportion of dry cat food, are risk factors for diabetes in the cat. However, the study did not take into account the fact that cats eat small prey when not confined indoors. The classic metabolic abnormalities found in type 2 DM, decreased insulin secretion, and peripheral insulin resistance, may be consequences of abnormal amyloid production by pancreatic cells. Middle-aged to older male cats with a history of obesity with a body condition score greater than 6 out of 9 are most at risk for the development of DM. Clinical signs of type 2 diabetes mellitus are subtle and progressive over a period of months to years, until finally blood glucose rises above the renal threshold, which is quite high in the cat, and polyuria and polydipsia ensue. Obesity with a body condition score over 6 out of 9, combined with fasting or postprandial hyperglycemia, may be the only clinical sign of early type 2 DM. Recently, increased body condition score has been associated with increased circulating concentrations of islet amyloid polypeptide, or IAPP, and insulin in obese non-diabetic cats. Cats affected with diabetic neuropathy will have trouble jumping onto high surfaces such as counters and beds, as the affected limbs are usually the hind limbs. The most common physical examination findings in cats are lethargy and depression, dehydration, unkempt hair coat, hepatomegaly, and muscle wasting. Diabetic cats can have a variety of clinical signs suggestive of diabetic neuropathy, including pain on palpation of distal extremities, hypersensitivity, gait abnormalities, and plantigrade stance. A diagnosis of diabetes mellitus should be based on the presence of clinical signs compatible with diabetes mellitus and evidence of fasting hyperglycemia with or without glycosuria. Many cats are susceptible to stress-induced hyperglycemia. Serum fructosamine is formed by glycosylation of serum protein, such as albumin, and the concentration of fructosamine in serum is directly related to blood glucose concentration. Serum fructosamine measurement may be beneficial in differentiating early or subclinical diabetes mellitus in the cat from stress-induced hyperglycemia. In cats, normal fructosamine concentrations may vary by laboratory, but one study suggested a range of 283 plus or minus 32 micromoles per litre. Common clinico-pathologic features of diabetes mellitus in cats include fasting hyperglycemia, hypercholesterolemia, increased liver enzymes such as ALP and ALT, neutrophilic leukocytosis, proteinuria, increased urine-specific gravity, azotemia, and glycosuria. The cat is an obligate carnivore and is unique in its insulin response to dietary carbohydrates. The feline liver exhibits normal hexokinase activity, but glucokinase activity is virtually absent. Glucokinase converts glucose to glycogen for storage in the liver and is important in mopping up excess postprandial glucose. Amino acids, rather than glucose, are the signal for insulin release in cats. Furthermore, cats have recently been shown to lack the sweet taste receptor, which is involved in incretin release and secondary beta cell function. Another unusual aspect of feline metabolism is the increase in hepatic gluconeogenesis seen after a normal meal. Normal cats maintain essential glucose requirements from gluconeogenic precursors, such as amino acids, rather than from dietary carbohydrates. As a result, cats can maintain normal blood glucose concentrations even when deprived of food for over 72 hours. In summary, the cat is uniquely adapted to a carnivorous diet. When type 2 diabetes occurs in cats, the metabolic adaptations to a carnivorous diet become even more deleterious, leading to severe protein catabolism. Feeding a diet rich in carbohydrates may exacerbate hyperglycemia and protein wasting in these diabetic cats. A low-carbohydrate, high-protein diet, which is similar in fact to a cat's natural diet, may ameliorate some of the abnormalities associated with diabetes mellitus in the cat. Initial studies using a canned high-protein / low-carbohydrate diet and the starch blocker acarbose have shown that 58% of cats discontinue insulin injections, and those with continued insulin requirements could be regulated on a much lower dosage, 1 to 2 units BID. In the only double-blinded controlled study of diet in feline diabetes mellitus, comparison of canned high-fiber versus canned low-carbohydrate diets showed that cats fed low-carbohydrate diets were 3 to 4 times more likely to discontinue insulin injections. The most recent studies show that approximately 70 to 90% of newly diagnosed diabetic cats can discontinue insulin injections when fed a restricted carbohydrate diet. Cats should be fed no more than 60 kilocalories per kilogram, about 210 kilocalories for an average cat, of ideal body weight in 2 equal meals per day. Caution should be used when initially changing from dry to canned foods, as insulin requirements may decrease dramatically. A reduction in insulin dosage may be required. Most canned cat food products will contain less than 10% carbohydrates on a dry matter basis, whereas dry food will usually contain more than 15% carbohydrate on a dry matter basis. Studies have shown that compared with PZI and lenti-insulins, glargine insulin is associated with the highest remission rates. Another option would be to use PZI insulin, which is associated with a little lower remission rate, around 70%, but is easier to administer and less costly. In either case, the author uses an initial dosage of 2 units per cat BD, as this dose has not been associated with hypoglycemia in the author's experience. For owners who prefer to give oral medication, glipizide has been used to successfully treat diabetes mellitus at a dosage of 2.5 milligrams BD when combined with a high-protein, low-carbohydrate diet. Monitoring newly diagnosed and treated feline diabetics can be challenging. The author prefers to use a slow method of remission induction using urine glucose monitoring at home coupled with periodic, every 3 weeks, serum chemistry, urinalysis, and fructosamine monitoring. The owner agrees not to increase insulin dosage based on urine glucose, but only to decrease the dosage if the urine glucose becomes negative. Continuous glucose monitors have recently been adapted for use in cats and may be more effective in determining if the cat is going into remission, if hypoglycemia is occurring, or whether adequate glucose regulation is being achieved. Source: VIN. Feline diabetes. World Small Animal Veterinary Association. World Congress Proceedings, 2014. Deborah S. Greco, DVM, PhD, DACVIM, Internal Medicine. Asbury Park, NJ, USA.